Good morning. My name is Barbara Carey. I'm a consultant in oral medicine in Guy's Hospital in London, and I want to say thank you to the organising committee for asking me to speak to you today on the topic of involvement of the salivary glands in systemic disease. I'm sorry I'm not there in person, but very happy to take any questions by email after the event. So today's talk will focus on the following systemic diseases affecting the salivary glands. So I'll focus on Sjogren's syndrome, IgG4 related disease and sialosis, and provide an overview on chronic graft-versus-host disease, infections of the salivary glands, eosinophilic sialodychitis, and drug-associated salivary gland diseases. I'll also mention the other rarer conditions with salivary gland manifestations. So xerostomia is the most common manifestation associated with the majority of these conditions, and the underlying mechanism differs in terms of disease. So this can be immune or inflammatory mediated in the case of viral infections and autoimmune conditions. It can be neuropathic in cases of diabetes or Parkinson's, and secondary to granulomatous reactions in sarcoidosis and TB. In storage diseases such as hemochromatosis and amyloidosis, there's deposition of iron or amyloid respectively in the salivary glands. Alteration in salivary gland structure is seen in conditions such as scleroderma, GVHD and CMV infection. And dehydration from end-stage renal disease or diabetes or from genetic conditions such as ectodermal dysplasia can also result in xerostomia. So in addition, various systemic diseases can also result in salivary gland swelling, and this can be unilateral or bilateral. So unilateral causes include Sjogren's syndrome and the associated non-Hodgkin's lymphoma, IgG4 related disease, sarcoidosis, sialolithiasis and amyloidosis. There's often an overlap with bilateral causes, which tend to include infections, Sjogren's syndrome, IgG4 related disease, sarcoidosis, sialosis, drugs, and reactions to iodine. Sjogren's syndrome is a systemic autoimmune condition resulting in lymphocytic infiltration of the salivary and lacrimal glands. It's more common in females with a ratio of 9:1, with a prevalence of 0.5 to 1.5% of the population. The onset is 4th to 6th decade. It is classified as a primary disease in which there are symptoms and signs of ocular and oral dryness, and secondary Sjogren's syndrome in which there is a connective tissue disorder, so most frequently rheumatoid arthritis or systemic lupus erythematosus, mixed connective tissue disorders, or systemic sclerosis. And patients with primary Sjogren's syndrome often have a spectrum of other systemic and often autoimmune phenomena, while those with secondary Sjogren's syndrome may also have oral manifestations of any accompanying connective tissue disease. So the main clinical features are oral and ocular dryness. The oral dryness can be profound and give rise to dysarthria and dysphagia. Extraglandular manifestations are not uncommon and can be non-specific and include symptoms such as fatigue, weight loss or fever. The arthritis seen in Sjogren's syndrome tends to be non-deforming. Arthralgia and myalgia are reported in 75% and 45% of cases respectively, and it may arise before the onset of lacrimal or salivary gland symptoms. Xerosis, or a dryness of the skin, and Raynaud's phenomenon are also seen, as are interstitial lung disease, primary biliary cirrhosis, glomerulonephritis, and a vasculitic rash. Neuropathy can be of any type and may be seen in the head and neck region where it can affect the trigeminal nerve. The most commonly used diagnostic criteria for a diagnosis of Sjogren's is the CEORL criteria published in 2017. Now, this is based on a point system where 1 point is awarded to each of unstimulated salivary flow rate of less than 0.1 ml per minute, a Schirmer's test of less than 5 millimeters in 5 minutes, or an ocular staining score of greater than 5. 3 points are awarded to Rho autoantibody positive or positive labia gland biopsy, which is defined as a focus score of greater than 1. So So a diagnosis of Sjogren's syndrome is made from a total of 4 or more. The American European Consensus Group criteria for a diagnosis of Sjogren's syndrome requires any 4 criteria, but it must include histopathology or autoantibodies, or 3 of the objective criteria. For a secondary Sjogren's syndrome diagnosis, there's a requirement for a well-defined major connective tissue disease and the presence of 1 symptom plus 2 objective criteria. So for the purpose of this talk, I'm going to focus on the oral and head and neck complications. So as I mentioned earlier, the oral dryness can be profound and give rise to dysarthria and dysphagia. In addition, it can give rise to dental caries, gingivitis, and candidal infection, as demonstrated here. So this is a patient with medium rhomboidoglositis involving the dorsum tongue, represented by the depapillated area. In addition, other types of candidal infections such as pseudomembranous candidiasis are common. Patients may also report dysgeusia or loss of taste. There may be intermittent swelling of the parotid glands, which reflects a non-specific inflammatory change, but there may also be solitary enlargement, which may reflect chronic silodenitis or non-Hodgkin's lymphoma. So Sjogren's syndrome is classed as a potentially malignant disorder associated with a 4.3% risk of malignancy. And these malignancies tend to be usually a low-grade marginal zone lymphoma, which can be follicle center, diffuse large B-cell lymphoma, or lymphoplasmacytoid lymphoma. And there are various risk factors for transforming into malignancy, including splenomegaly, lymphadenopathy, salivary gland enlargement, and on hematological investigations, a low C4, high beta-2 macroglobulin, a low CD4 count, low IgM, and mixed cryoglobulinemia. So ultrasound does not form part of the diagnostic criteria for Sjogren's syndrome, but it is a useful tool in terms of surveillance. The British Society for Rheumatology published their guidelines on management of Sjogren's disease in April of this year. From a caries prevention perspective, it's important to give patients appropriate oral hygiene instruction and dietary advice, and consider a topical fluoride application with the patient's dentist. Candidal infections can be treated with topical or oral antifungal therapy, including nisatinol suspension, miconazole oral gel, or fluconazole, and often patients require intermittent courses of antifungal therapy. Saliva-stimulating agents include sugar-free gum and sugar-free sweets, saliva-stimulating tablets, glandosane spray, and pilocarpine. Pilocarpine works on the muscarinic acetylcholine receptors M1 and M3 present in the salivary glands, and this leads to increased secretory function. However, it is contraindicated in patients with asthma, arrhythmias, and glaucoma, and there are lots of intolerable side effects reported by patients, so that limits its use. In terms of replacements, biotin oral gel or saliva orthana spray can also be used. And it is important to note that there is no evidence at present that any systemic or immunologically active agents can reduce the oral dryness of Sjogren's syndrome. Other autoimmune diseases are also known to affect the salivary glands. Rheumatoid arthritis frequently presents with dysfunction of the lacrimal and salivary glands, and secondary Sjogren's syndrome is associated with xerostomia and is most frequently associated with rheumatoid arthritis. In addition, more than 75% of patients with systemic lupus erythematosus are affected with xerostomia, and a coexistence of Sjogren's syndrome and SLE is seen in 1/3 of these patients. Xerostomia is observed in 43 to 73% of patients with primary biliary cirrhosis, and in patients with scleroderma there's fibrosis of capillaries and excretory duct and acini of the salivary glands, with lymphocytic infiltration observed in 15% of patients. Now moving on to IgG4 related disease. So this is a rare, chronic, relapsing remitting fibroinflammatory disorder which can involve almost any organ. The etiology is unknown, but it was recognized as a distinct entity in 2003. and it encompasses many conditions with common histopathological features which include autoimmune pancreatitis, Michelot's disease and chronic sclerosing cholangitis. The disease process itself involves the accumulation of IgG4 positive plasma cells, leading to mass formation, inflammation and fibrosis, causing impairment and damage to tissues. It mimics many neoplastic, inflammatory and infectious diseases, and often this leads to diagnostic delay. The submandibular glands tend to be commonly affected, and in the past this was often termed Michelot's disease, Kuttner's tumors, or chronic sclerosing sialadenitis. The primary salivary gland features are long-standing and generally asymptomatic swelling with or without symptoms of xerostomia. The disease prevalence is approximately 3 per 100,000. It's more common in males, typically in their 60s, in contrast to autoimmune conditions. In the head and neck region, it affects males at a 1.6 to 1 ratio, and at other sites 4 to 1. The pathophysiology can be separated into two phases, of which the first includes B and T lymphocytes accumulating at the site of disease, specifically plasmablasts that express SLAM-F7 and the release of pro-inflammatory cytokines. This is then followed by a fibrotic phase in which the pro-fibrotic cytokines activate fibroblasts to deposit extracellular matrix, resulting in organ impairment. 4 broad phenotypes have been identified, and these include pancreatobiliary, retroperitoneal, head and neck limited, and systemic. This provides a framework for understanding likely disease sites of involvement. However, patients may not necessarily fit into a specific phenotype. Therefore, all patients require a systematic approach to investigation. Often the diagnosis is made on exclusion of other more common conditions and building on previous investigations. MDT input from professionals working in different specialties is often required. In 2019, the CEORL classification criteria was developed, and this outlines a 3-step process that includes entry, exclusion, and inclusion criteria as shown on the right. A score of 20 or more in the inclusion criteria, which includes clinical, serological, and histological criteria, satisfies the diagnosis of IgG4-related disease. Early recognition and diagnosis are crucial to assess the extent of disease and to prevent further tissue damage. Management can be split into 2 phases. Remission induction, which typically involves oral prednisolone, though rituximab has also been used. Remission maintenance is achieved with low-dose prednisolone, DMARDs, as shown here, and rituximab. And surgical excision of the affected gland can sometimes be advocated. Sialosis is an uncommon, non-neoplastic, non-inflammatory, non-infective disorder that can affect the salivary glands. It presents as bilateral, non-painful enlargement of the major salivary glands, usually the parotids. It's of gradual onset, usually in middle to late life. It is characterized by persistent enlargement of the gland, and xerostomia is not a common symptom. The etiology is unknown, but it may be a neuropathy that results in dysregulation of autonomic control, leading to loss of parasympathetic activity and an increase in sympathetic drive, leading to an unopposed increase in protein content within the acinar cells. This would explain the association with drugs, alcohol, endocrine conditions such as diabetes and hypothyroidism. In patients with bulimia, the degree of salivary gland enlargement possibly correlates with the frequency of bulimic symptoms and with levels of serum amylase. It is a diagnosis of exclusion, though various hematological and imaging investigations may be undertaken. Biopsy is rarely warranted, but histopathology is characterized by sinner cell hypertrophy and atrophy of the striated ducts associated with edema of the interstitial connective tissue and widespread fatty replacement of the acini. The condition is often resistant to treatment, and rarely surgical reduction of the gland is required. Chronic GVHD, or graft-versus-host disease, is the most important complication in long-term survivors following allogeneic stem cell transplantation, with almost 50% of patients developing the disease. Oral manifestations are common and often the initial site of involvement. Xerostomia is the most common oral symptom, reporting 77% of patients, and 59% of patients diagnosed with chronic GVHD have salivary gland dysfunction, manifesting as a Sjogren's-like picture. There is evidence of a lymphocytic infiltration, parenchymal destruction and fibrosis within the salivary gland tissue. And another oral feature includes the presence of mucoceles, particularly on the hard palate, which may be secondary to localized inflammation. And these patients are at higher risk of developing secondary solid tumours. Now moving on to infections. So approximately 10% of adults and children with untreated HIV infection can present with salivary gland involvement. And this presents as recurrent or persistent major salivary gland enlargement and xerostomia. The parotid gland is most frequently affected, often in a bilateral pattern. It may also occur as part of a diffuse infiltrative lymphocytosis syndrome, where there's CD8 positive T cell infiltration of the salivary glands, lacrimal glands, and lungs. Current evidence suggests that the inflammation and cyst formation may be driven by an infection with BK polyomavirus. The clinical picture mimics Sjogren's syndrome, and benign lymphoepithelial cysts or lesions may also occur. Drug-related adverse effects are also reported, with some nucleoside analog HIV reverse transcriptase inhibitors and protease inhibitors resulting in xerostomia. There have been rare reports of silolithiasis secondary to atazanavir, ranular formation, and submandibular gland swelling secondary to CMV. Mumps typically presents with major salivary gland involvement, but usually diminishes after 4 to 5 days, and this may precede more complicated aspects of the illness. There's also been a small number of reports of transient facial nerve weakness. Xerostomia has been reported in 5 to 55% of hepatitis C infected patients. And there's evidence of lymphocytic infiltration of the salivary gland tissue with a more predominant cytotoxic T cell infiltrate. Xerostomia is also reported to be an adverse effect to drug therapy. Other viral infections known to infect the salivary glands include the Epstein-Barr virus, cytomegalovirus, and HTLV1. The salivary glands may also be involved in cases of actinomycosis, which can colonize the ducts of the submandibular and parotid glands, resulting in abscess formation. Patients with tuberculosis may experience xerostomia and/or salivary gland swelling and granuloma or cyst formation within the affected glands. Eosinophilic sialidocytis is a rare cause of recurrent salivary gland swelling. The condition is associated with eosinophil-rich mucus plugs, or histological evidence of eosinophilic infiltration around larger salivary gland ducts. The condition is characterized by swelling of the salivary glands with or without pain or discomfort and itch of the overlying skin. The patient often reports a history of multiple episodes of recurrent gland swelling, a reduction in salivary flow, and stringy secretions from the parotid or submandibular duct. Though not strictly a systemic disease, there is often a history of allergy, and support for an allergic etiology is based on the high prevalence of atopy in affected patients, high levels of peripheral blood eosinophils in some patients, and histopathological similarity to asthma. The condition really should be suspected in those middle-aged female of black origin who are atopic, asthmatic, or may suffer with allergic rhinitis, presenting with symptoms of salivary gland swelling. Here on the right is the presentation of symptoms in our cohort of 37 patients under our caring guise, and you can see that swelling, itch, pain and discomfort, string-like mucus discharge and meal-type symptoms are the predominant presentation. A wide range of drugs can cause salivary gland diseases. A transient and mild acute sialadenitis, sometimes termed iodide mumps, can arise in response to iodine-based contrast media. Similarly, radioactive iodine used for the treatment of thyroid cancer can cause salivary gland swelling and xerostomia that may arise within 24 hours of therapy and persist for a few weeks. Over 500 drugs can cause dry mouth, with the method of action being anticholinergic and symptomimetic effects. Tricyclics, benzodiazepines, atropinics, beta blockers and antihistamines are the most common culprits. Salivary gland swelling due to other agents listed here has also been well described, and as discussed earlier when talking about HIV, atazanavir and sialolithiasis association has also been described. And finally, moving on to other disorders that may present with salivary gland involvement. So sarcoidosis is a systemic inflammatory disease with unknown etiology characterized by the presence of non-caseating granulomas. It typically affects the lungs and lymph nodes, but xerostomia and salivary gland involvement has been reported in up to 9% of patients, and this often occurs as part of Hereford syndrome. In Crohn's disease, there's been reports of minor salivary gland involvement, though this is rare. In Wegener's granulomatosis, or GPA, major salivary gland enlargement has been reported. Hemochromatosis is characterized by iron deposition in the salivary glands, which may result in hyposalivation. Similarly, amyloidosis can result in amyloid infiltration and destruction of the salivary glands, leading to dry mouth. In patients with diabetes, they may present with sialosis, which we have discussed, but dry mouth may be secondary to polyuria, dehydration, and autonomic neuropathy. In patients with thyroid disease, primary Sjogren's syndrome has been reported to be 10 times more frequent in patients with autoimmune thyroid disease, and autoimmune thyroiditis has been found to be 9 times more frequent in primary Sjogren's syndrome. Xerostomia has been reported in 28 to 59% of patients with end-stage renal disease. Impaired salivary gland secretion has been documented as an early manifestation of Parkinson's disease. In those with hyperparathyroidism, patients with sialolithiasis have a greater risk of development of nephrocalcinosis than those without sialolithiasis. And finally, long-standing anxiety and depression can also result in xerostomia. So in conclusion, the salivary glands are involved in many systemic diseases with the resultant complication of xerostomia or salivary gland enlargement. The underlying mechanism of xerostomia differs in terms of the disease. Identification of the main cause of xerostomia helps attain timely diagnosis and a more appropriate treatment plan. Thank you very much for your attention. I'm very happy for any questions to be directed to me at barbaracarey@nhs.net. Thank you.